Okay, if the other attendee joins, I will let them in through the waiting room. But for now, I want to thank you for joining us tonight for the GHAPP MASLD Community Network meeting. My name is Christine, and I'll be your moderator tonight. There will be an opportunity to ask questions live at the end of the presentation and network with the other participants. But for now, I will pass things on to Summer. Thank you.
Right. Thanks, Christine. Okay, so welcome and thank you for joining today's session on MASLD basics. My name is Summer Collier. I'm a nurse practitioner at UC San Diego Health, and I'm excited to walk you through this overview as part of our MASLD network case series. And today we'll cover foundational concepts, evolving nomenclature, clinical evaluation and management, strategies to support your practice regarding MASLD and MASH. And so before we begin, if you're not already registered for the meeting, here is a QR code to register. You can also access additional materials through this QR code. And then I encourage you to also visit the GHAPP MASLD MASH Community Network, where you'll find Madrigal's educational tools and information on the medication Rezdiffra. Rezdiffra is a part of an evolving therapeutic landscape for MASLD and MASH. And so the overarching term of steatotic liver disease, or SLD, was chosen to classify individuals with hepatic steatosis due to various etiologies. And steatosis is typically picked up either on imaging or sometimes on a biopsy done for other reasons. And so MASLD is the part of this steatotic liver disease grouping. MASLD stands for metabolic dysfunction-associated steatotic liver disease, and it includes both MASLD and the more aggressive form of MASH. And then within this category of SLD, we also have MET-ALD, which is MASLD, but in patients that have an increase in alcohol intake. And so MET-ALD includes both the metabolic risks as well as the alcohol-associated liver disease risks. And then we have alcohol-associated liver disease, or ALD, and this is the patients that have steatosis related to an increase in alcohol intake. And then along this, we have less common etiologies such as drug-induced liver injury that can cause steatosis, or monogenic diseases, or cryptogenic SLD. And so when we think of the MASLD definition, to meet the definition or to meet the diagnosis of MASLD, we really need to have a patient with hepatic steatosis. And again, this is identified commonly by imaging. So sometimes this is picked up incidentally on imaging, or in some cases it's picked up on biopsy. So we need steatosis, plus we need evidence of metabolic disease. The definition really includes steatosis plus at least 1 out of 5 cardio-metabolic risk factors. These include an elevated BMI or a larger waist circumference, prediabetes or diabetes, hypertension or being on an antihypertensive medication, an elevated triglyceride level or HDL, or being on a statin or other cholesterol-lowering medication. And importantly, we have to continue to think about MASLD as a diagnosis that excludes patients that have significant or an increased level of alcohol use. Significant alcohol use is typically defined as greater than 30 grams of alcohol per day in men and more than 20 grams of alcohol per day in women. So MASLD is now the standard term, replacing the former term of NAFLD, and MASH now replaces the former term of NASH. And there is substantial overlap, so these really are not a new diagnosis, it's just a change in the nomenclature. And so I suggest that there's a 99% overlap between the MASLD-defined population and the historical NAFLD-defined populations. And so because of that, all recommendations that have been already established by organizations such as the AASLD practice guidance on NAFLD can now be applied with MASLD and MASH. And any historical results from studies on natural history or biomarker validation that were done in the patient population of NAFLD and NASH are applicable to patients with MASLD and MASH. Classification really aims to better reflect the pathophysiology that is connected to metabolic disease and steatotic liver disease, and also to reduce the stigma that's been associated with terms like non-alcoholic or terms such as fatty liver. And so just to reiterate, but MASLD is the presence of hepatic steatosis plus a cardio-metabolic risk factor in the absence of significant alcohol use. Through this, so primary care is often the first line in identifying patients with MASLD, and it is important that primary care and really everyone that's interacting with patients with metabolic risk are aware of easy screening tools that can be done to risk stratify patients with MASLD. And so one of the tools that is recommended to use is called the FIB-4, and it's a clinical tool. It's a non-invasive tool that can help to predict the risk of advanced fibrosis. And this calculator uses values that we typically readily have on hand, such as a patient's age, platelet value, ALT, AST value, and then it can give us a number, and we use that number to understand if the patient is at very low risk or if they have a high risk of having liver fibrosis. And so this slide shows kind of how to utilize the FIB-4 in a primary care setting. And so when you have a patient that you have concern, they may have MASLD, or you have imaging that shows they have steatotic liver disease, you can use this FIB-4 calculator. And if they have a value of less than 1.3, they have very low risk of having significant liver fibrosis. And so with that, we would encourage a conversation around lifestyle changes, maybe weight loss approaches, making sure that the cardiometabolic risk factors are in better control. So if they are pre-diabetic, that there's education regarding that, or if they're overweight, there's education on weight loss, and then to reassess the FIB-4 on either an annual basis if they have type 2 diabetes or more than 2 metabolic risk factors, or every 2 to 3 years if they have no diabetes and really only 1 or 0 metabolic risk factors. And then for patients that have a higher than 1.3 FIB-4 score, but less than 2.67, they fall into this indeterminate range. And so the FIB-4 is not great at assessing whether they have mild fibrosis or moderate fibrosis. And so we recommend the next steps in primary care to do a non-invasive assessment of fibrosis. And this may look differently depending on where you practice, but typically a FibroScan would be ordered, which is an office-based, ultrasound-based tool that can be completed with a patient that gives a really good estimate of liver fibrosis. If that's not available, then sometimes the radiology locally will have the ability to do a shear wave elastography, which is a different type of an ultrasound-based non-invasive test for fibrosis. And if that's not available, then there is a laboratory test that can help to estimate fibrosis, and that's called the ELF test. And so based on that, if it's considered low risk, based on either the FibroScan or the ELF test, then you can go back to reassessing with a FIB-4 every 1 to 3 years based on the patient's risks. And if that FIB-4 initially was in that more high risk or greater than 2.67, or the next step FibroScan showed more intermediate or higher risk assessment, then we'd encourage a referral to specialty care and hepatology. And their goal really to involve these patients earlier with hepatology care is to identify patients that have more significant fibrosis, to identify patients that have a diagnosis of cirrhosis, and engage them in ongoing screening and individualized care to monitor for the risks of liver disease progression and risk of liver cancer. So once advanced fibrosis is suspected, either clinically through non-invasive testing or by imaging, then hepatology really should take the lead. The fibrosis staging helps guide management. Patients, even if they get referred to hepatology and we do more testing, we find that they're really low risk for fibrosis, they may be referred back to primary care with a recommendation to be reassessed every 1 to 3 years. For patients that are more moderate fibrosis, so this would be a stage 2-3 fibrosis, we typically reassess that fibrosis staging annually, and we would consider pharmacotherapy to help to slow that progression, maybe even regress some of the fibrosis and steatosis. And then in stage 4 or cirrhosis, we'd of course start start cirrhosis management in the hepatology setting. Sometimes there is testing that doesn't quite match. And so we may have a FIB4, let's say, that's very high, and non-invasive testing that looks normal. And so what do we do with that? And so sometimes in those situations, we'll have to go to liver biopsy, and then that can be really considered the gold standard for diagnosis and for staging. And so there are some cases where we do liver biopsy. And in some other cases, if we have concern of other types of liver conditions or diagnoses, along with the steatotic liver disease, we may also need to do biopsy. For the most part, we can assess these patients pretty adequately with non-invasive testing. And this is just, if you suspect cirrhosis, there's no need to, if we suspect cirrhosis, we're going to initiate that cirrhosis-based management. All right, so MASLD, this is looking more globally about the epidemic of MASLD. And so it really is a true global epidemic. In North America, the rates of MASLD is around 30%. But in Latin America, in the Middle East, it's even higher. And in some Asian countries, Southeast Asia, it's a little bit higher. These numbers typically reflect shifts in diets, urbanization, rising rates of obesity and metabolic syndrome, as well as some genetic predisposition to MASLD. And this slide just reinforces the urgency, really, of all providers to work together, all specialties to work together to identify those patients at risk and to be able to intervene and guide our patients earlier in the disease process. So here's a visual of that MASLD progression and the natural history of MASLD. And so, a third of American adults are predicted to have a diagnosis of MASLD, affecting around 60 to 80 million Americans. And about 20% of those patients have the more progressive form of steatotic liver disease, or MASH. Fibrosis progression in MASH is typically quite slow. It usually progresses in one stage per 7 years. But in about 20% of patients with MASH, we do see a more rapid progression, and they can progress to cirrhosis in 10 years. MASH itself has a slight increased risk of hepatocellular carcinoma, or primary liver cancer. Patients that have more advanced fibrosis have an increased risk of cancer, as well as, of course, with patients with cirrhosis of really any cause, have an increased risk of cancer. And that risk of cancer, as well as the risk of cirrhosis, can lead to worsening liver function, liver failure, the need for liver transplantation, and liver-related death. Here's another slide that just is a visualization of that progression as well. And it kind of looks at different contributions that may predispose the patient to more rapidly progress to cirrhosis. These are genetic findings that can lead to a more rapid progression. And they're found as well as patients that have obesity, diabetes, metabolic syndrome, and alcohol use have a higher risk of progressing to a more advanced fibrosis and cirrhosis. And so just to reiterate a few key points, MASLD affects 60 to 80 million Americans. The key takeaway is that MASH with fibrosis stages 2 to 4 is associated with the greatest risk of liver-related morbidity and mortality. Cardiovascular disease remains the leading cause of death in patients with MASLD without advanced fibrosis. And for those with cirrhosis, liver-related deaths dominate. And this emphasizes the value of fibrosis staging in prognosis and in treatment planning. Okay, so now let's apply this baseline knowledge to a patient presentation. And so this is JP. He is a 55-year-old man referred to your clinic with mild aminotransferase elevations. He's gained 20 pounds over the last 5 years and has central adiposity, prediabetes, and hypertension. His liver enzymes are, his liver enzymes are only mildly elevated. They're ALT of 45, AST of 50. And this is really a classic presentation for MASLD. And so this patient has metabolic risk factors. He has prediabetes. He's obese. He's got hypertension. He's had recent weight gain, and he has mild elevations in his liver enzymes. Of note, his social history, he's got really rare alcohol use. So we can rule out that alcohol is contributing to the steatotic liver disease. And his one medication is lisinopril. And so when we have a referral, even when, the patient is the perfect phenotype for MASLD, we want to make sure that we're not missing any other etiologies of elevated liver enzymes or etiologies of steatosis. And so We want to always consider that alcohol is not playing a part. Encourage you to use not just a history, but a validated alcohol use screening like an audit or a lab test to evaluate for objective alcohol use, or to evaluate objectively alcohol use. And then you want to look for medications. And so our patient was only on lisinopril, so we can rule that out as a medication that was contributing to a steatosis. But in some patients, you may have a history of amiodarone, methotrexate, tamoxifen, 5-FU, corticosteroid history, valproate acid for seizures, or antiretrovirals for HIV, especially some of the older antiretrovirals that were used. And then you want to look at any other reason for elevated liver enzymes, any other etiologies that may contribute to chronic liver disease. This may be viral hepatitis, Wilson's disease or copper overload, hemochromatosis, lipodystrophy in the setting of HIV. History of anorexia, history of chronic disease that caused a lot of malnutrition, or celiac disease, post-Whipple, parenteral nutrition, any inborn errors of metabolism, ALD, or some protein deficiencies. And so when we have that first consult with this patient, typically we want to do a further evaluation and we send off laboratory evaluation. And this is typically more in a patient that's been referred to a specialty setting, but you can also consider doing this screening if you have a patient with elevated liver enzymes in a primary care setting as well. So you want to evaluate for viral hepatitis serologies, the iron markers to screen for iron overload or hemochromatosis, autoimmune markers that could suggest autoimmune hepatitis, including AMA, ANA, and ASMA. The celiac panel to screen for any malnutrition that may be causing steatosis. Alpha-1 antitrypsin level, which screens for A1AT deficiency. Of course, CBC-CMP-INR if you're concerned for advanced fibrosis. This is what you would use to calculate a MELD score, which is helpful in the prognosis of liver disease. Make sure that patient has been screened at some point for HIV or repeat it if there's ongoing risk factors. Lipid panel, A1C for metabolic disease screening, a thyroid function panel to rule out untreated hypothyroidism as a cause for elevated ALT. And then this PEth value is a blood test that is a marker for alcohol metabolites, and it can detect frequent or heavy alcohol use in the weeks and sometimes month before the lab test. So it's a good objective marker for problematic or increased alcohol use. And then abdominal ultrasound, of course, is really helpful. And oftentimes this is already done. And this is what, caused the red flag to wonder if this patient has steatosis. And so on ultrasound, you're going to see an increase in echogenicity in the liver that suggests steatosis. And the top picture here is a healthy liver and then a kidney. And so they're very similar. A healthy liver should look very similar in the grayscale contrast to a kidney. And then in the lower picture, you'll see the increased echogenicity of the liver. It's grayer. It makes the kidney look darker. And that's a sign of steatosis. And it's important to note that even if you have a high suspicion of MASLD, but you have a normal ultrasound, the ultrasound does not show steatosis. It does not necessarily exclude steatosis. Ultrasound's very good at detecting moderate or severe steatosis, but some of the mild steatosis can definitely get missed on ultrasound. So back to our patient. So our patient completed an ultrasound. It showed increased hepatic echogenicity. It was suggestive of steatosis. There's no signs of portal hypertension, which can be seen in later stage fibrosis or cirrhosis. And so this is a typical impression on an ultrasound for a patient with early stage MASLD. However, ultrasound, doesn't tell us the staging of fibrosis. Ultrasound doesn't really tell us the amount of inflammation to the steatosis or to the liver. And so it's just kind of one tool we have in this workup. So not all, I'm kind of touched on this before, but not all patients that have MASLD require a liver biopsy. In fact, we can usually not do liver biopsy for many patients with MASLD. It's helpful in some situations, especially when there's non-invasive testing that is indeterminate, or conflicting or not possible to complete. Some of our patients with a BMI of 40 or higher may not have a really valid test on some of the non-invasive testing, and we may need to proceed with liver biopsy. Sometimes there's discrepancy in the FIB4, sometimes there's discrepancy in what the imaging looks like compared to the non-invasive testing. And so it can be kind of a tool that we use to better understand the diagnosis, to more properly stage fibrosis. And then it's really the only way that we can definitively understand MASLD versus MASH. MASH is the more inflammatory type of fat in the liver, but that does not always need it. If we have a patient that has a lot of cardio-metabolic risk factors, elevated liver enzymes, and steatosis, we can kind of make that conclusion that they have MASH with the tools we have without biopsy. And so for our patient, JP, we know that he has steatotic liver disease because of his imaging. We know that through our blood workup, our serological workup, we know that we were able to exclude other causes of liver disease. We know that this patient has metabolic risk factors. We know that his BMI is elevated. He has a diagnosis of prediabetes, and he is on antihypertensive medication. And we know from history, as well as that objective PEth marker, that he is not drinking alcohol that would lead to steatosis. And so we can give him a diagnosis now of MASLD. And so kind of going to turn this over kind of to the group or for you to think about. But for this case, the primary questions that we still need to answer is, does this patient have underlying steatohepatitis? Does this patient have any fibrosis? And how would we know? What would be our next steps to understand his fibrosis? And does this patient have evidence of advanced F3 or F4 fibrosis? These, this really helps us to know what our next steps are. So I guess if we are going to do a non-invasive testing, let's say we end up doing a FibroScan and it was elevated in the F2, F3 range, then this would be a good candidate that we may consider pharmacotherapy for. If we did a further assessment through FibroScan or other non-invasive testing and he had really low risk fibrosis, let's say he had no fibrosis or F1, then we would, really work with him about lifestyle changes, keep a close eye, maybe re-monitor, restage in a year. And hopefully he's lost weight, hopefully his blood sugars are well controlled, and he remains in this low risk group. And I think that's the end of my slides.